We'll begin our third part of the section on burns, the acute phase of injury. This phase begins with the mobilization of the extracellular fluid and subsequent diuresis, and concludes when the partial thickness wounds are healed and or the full thickness burns are covered by skin grafts. This may take weeks to months. Diuresis from fluid mobilization occurs and the patient becomes less edematous. Bowel sounds return and healing begins as the white blood cells surround the burn wound and phagocytosis occurs. The depth of the burn wounds may be more apparent as they declare themselves as partial or full thickness. The patient may now become aware of the enormity of the situation and will benefit from psychosocial support and information. The necrotic tissue begins to slough, granulation tissue forms, partial thickness wounds heal from the edges and from the dermal bed, and full thickness burns must have the eschar removed and skin grafts applied. Often, healing time and the length of hospitalization are decreased by early excision and skin grafting. Partial thickness wounds form eschar. Once the eschar is removed, reepithelialization begins. The epithelial buds from the dermal bed eventually close in the wound, which then heals spontaneously without surgical intervention, usually within 10 to 21 days. Full thickness wounds require debridement. The margins of the full thickness eschar take longer to separate. As a result, full thickness wounds require surgical debridement and skin grafting for healing. MK begins to diurese and his facial and body edema subside. He's taken to the OR again for further debridement and skin grafting. So what laboratory values do you need to monitor? And what imbalances is he at risk for at this stage of the game? Well, hyponatremia can develop from excessive GI suctioning or diarrhea, and water intoxication can occur. The manifestations of hyponatremia include weakness, dizziness, muscle cramps, fatigue, headache, tachycardia, and confusion. The burn patient may also develop a dilutional hyponatremia called water intoxication. To avoid this condition, the patient should drink fluids other than water, such as juice, soft drinks, and nutritional supplements. Hypernatremia may develop following successful fluid replacement, improper tube feedings, and inappropriate fluid administration. It may be seen following successful fluid resuscitation if copious amounts of hypertonic solutions were required. The manifestations of hypernatremia include thirst, dried furry tongue, lethargy, confusion, and possibly seizures. Restrict sodium in the IV and oral feedings. Hyperkalemia may occur if the patient has renal failure, adrenocortical insufficiency, or massive deep muscle injury. Large amounts of potassium are released from the damaged cells. Hyperkalemia can cause cardiac dysrhythmias and ventricular failure, muscle weakness, and EKG changes. Hypokalemia can be caused by lengthy IV therapy without potassium, vomiting or diarrhea, or prolonged gastrointestinal suctioning. Signs and symptoms of hypokalemia include fatigue, muscle weakness, leg cramps, paresthesias, and decreased reflexes. Complications that you might see include infection. The body's first line of defense, the skin, is destroyed by the burn injury. The burn wound is now colonized with the person's organism. If the bacterial density at the junction of the eschar with underlying viable tissue rises to greater than 10 to the 5th gram of tissue, The patient has a burn wound infection. Invasive wound infections may be treated with systemic antibiotics based on culture results. So watch for signs and symptoms of infection, which include hypo or hyperthermia, increased heart rate and respiratory rate, decreased blood pressure, and decreased urine output. Mild confusion, chills, malaise, and loss of appetite may be observed. The white count will usually be between 10 and 20,000. Functional defects in the white cells are noted, and the patient remains immunosuppressed for a period of time after the burn injury. The causative organisms of sepsis are usually gram-negative bacteria such as Pseudomonas or Proteus, putting the patient at further risk of septic shock. When sepsis is suspected, cultures are immediately obtained from all possible sources, including the burn wound, blood, urine, sputum, oropharynx, and perineal regions, and the IV site. Treatment immediately begins with antibiotics appropriate for the usual resident flora of a particular burn center. When the culture and sensitivity results are known, the antibiotic in use may be continued or changed based on those results. At this stage, the patient's condition is critical, requiring close monitoring of vital signs and collaboration with the infectious disease service is important to ensure appropriate antibiotic coverage. At week 4, MK develops a temperature of 102, pulse is 98, and respirations are 22. He has increased redness over his neck region burns and some pus-like drainage, and he started on a broad-spectrum IV antibiotic. What precautions can you take to treat MK's infections, and what other complications is he at risk for? The complications that were present in the emergent phase may continue into the acute phase. In the neurologic system, there are no physical symptoms unless there's severe hypoxia from respiratory injuries or complications from electrical injuries. Then there may be disorientation or combativeness. Probable causes of neurologic complications include electrolyte imbalance, stress, cerebral edema, sepsis, sleep disturbances, and the use of analgesics and anti-anxiety drugs. However, some patients may demonstrate certain behaviors that are not completely understood. The patient can become extremely disoriented and may withdraw, or may become combative. Delirium is more acute at night and occurs more often in the older patient. Focus on nursing strategies to orient and reassure your patient if he or she is confused or agitated. This is a transient state, lasting from a day or two to several weeks, but complications and sequelae can last for years and can be quite serious. The musculoskeletal system is particularly prone to complications during the acute phase, and the involvement of both the physical and occupational therapist is vitally important. As the burns begin to heal and scar tissue forms, the skin is less supple and pliant. Range of motion may be limited and contractures can occur. Because of pain, the patient will prefer to assume a flexed position for comfort. You should encourage the patient to stretch and move the burned body parts as much as possible. Splinting can be beneficial to prevent or reduce contracture formation. With the gastrointestinal system, paralytic ileus can be caused by sepsis. Diarrhea can result from the use of enteral feedings or antibiotics. Constipation can occur as a side effect of opioid analgesics, decreased mobility, and a low-fiber diet. Curling's ulcer is a type of gastroduodenal ulcer characterized by diffuse superficial lesions, including mucosal erosion. It's caused by the generalized stress response due to decreased blood flow to the GI tract. Aim to prevent Curling's ulcer by feeding the patient as soon as possible after the burn injury. Antacids, H2 histamine blockers like ranitidine, and protein pump inhibitors like Nexium are used prophylactically to neutralize stomach acids and inhibit histamine and the stimulation of hydrochloric acid secretion. Patients with major burns may also have occult blood in their stools during the acute phase, and this requires monitoring for bleeding. Observe for transient increases in the patient's blood glucose levels as a result of stress-mediated cortisol and catecholamine release, resulting in increased mobilization of glycogen stores, gluconeogenesis, and subsequent production of glucose. An increase in insulin production and release is noted. However, the effectiveness of insulin is decreased because the relative insulin insensitivity leads to an elevated blood glucose level. Hyperglycemia may also be caused by an increased calorie intake necessary to meet some patients' metabolic requirements. When this occurs, the treatment is supplemental IV insulin, not decreased feeding. Check blood glucose levels frequently and give insulin as ordered. Point-of-care testing of glucose can be done, but serum glucose testing is more accurate. As the patient's metabolic demands are met and less stress is placed on the entire system, the stress-induced condition is reversed. The predominant therapeutic interventions in the acute phase are wound care, excision and grafting, pain management, physical and occupational therapy, and nutritional therapy. The goals of wound care are to prevent infection by cleansing and debriding the area of necrotic tissue that would promote bacterial growth, and to promote wound reepithelialization and/or successful skin grafting. Wound care consists of ongoing observation, assessment, cleansing, debridement, and dressing applications. Non-surgical debridement, dressing changes, topical antimicrobial therapy, graft care, and donor site care are performed as often as necessary, depending on the topical cream or dressing ordered. Enzymatic debriders made of natural ingredients such as collagen may be used for enzymatic debridement of burn wounds, which speeds up the removal of dead tissue from the healthy wound bed. Wounds are cleansed with soap and water or normal saline moistened gauze to remove the old antimicrobial agent gently and any loose necrotic tissue, scabs, or dried blood. During the debridement phase, cover the wound with topical antimicrobial creams like silver sulfadiazine or silver impregnated dressings. When the partial thickness burn wounds have been fully debrided, a protective, coarse or fine meshed, grease-based paraffin or petroleum gauze dressing is applied to protect the reepithelializing keratinocytes as they resurface and close the wound bed. If grafting is necessary, protect the skin graft with the same greasy gauze dressing next to the graft, followed by saline moistened middle and dry gauze outer dressings. With facial grafts, the unmeshed sheet graft is left open, so it's possible for blebs, or serosanguinous exudates, to form between the graft and the recipient bed. Blebs prevent the graft from permanently attaching to the wound bed. The evacuation of blebs is best performed by aspiration with a tuberculin syringe and only by those who have received instruction in this specialized skill. Management of full-thickness burn wounds involves early removal or surgical excision of the necrotic tissue followed by application of split-thickness autograft skin. This therapy has changed the management and survival rate of burn patients. In the past, patients with major burns had low rates of survival because healing and wound coverage took so long that the patient usually died of sepsis or malnutrition. Because of current earlier intervention, mortality and morbidity rates have been greatly decreased. Many patients, especially those with major burns, are taken to the OR for wound excision on day 1 or 2 The wounds are covered with a biologic dressing or allograft for temporary coverage until permanent grafting can occur. Devitalized tissue, or eschar, is excised down to the subcutaneous tissue or fascia, depending on the degree of the injury. Surgical excision can result in massive blood loss. Topical application of epinephrine or thrombin, application of extremity tourniquets, and application of new fibrin sealant are all work to decrease surgical blood loss. Once hemostasis has been achieved, a graft is then placed on clean, viable tissue to achieve good adherence. Whenever possible, the freshly excised wound is covered with autograft or the person's own skin. Recently, fibrin sealant has been used to attach skin grafts to the wound beds. Grafts can also be stapled or sutured into place. Temporary allograft can be used to test the suitability of the recipient site to accept a graft. The allograft is then removed several days later in the OR and an autograft applied. With early excision, function is restored and scar tissue formation is minimized. Clots between the graft and the wound keep the graft from adhering to the wound. Outer occlusive dressings apply just enough pressure to promote adherence of the graft to the wound bed and help to control bleeding. Frequent observation for bleeding and circulatory problems and appropriate nursing interventions can help identify and manage complications that would interfere with graft survival. Facial, neck, and hand burns require skilled nursing care to identify and manage clots quickly for the best functional and aesthetic outcomes. This is a picture of a split thickness sheet skin graft of a hand. This is a donor site being harvested. Donor skin is taken from a patient for grafting by means of a dermatome, which removes a thin 14 to 16 1/1000ths of an inch split thickness layer of skin from an unburned site. The donor skin can be meshed, usually a ratio of 1.5 to 1, to allow for greater wound coverage, or it may be applied as an unmeshed sheet for a better cosmetic result when grafting the face, neck, and hands. The donor site now becomes a new open wound. The goals of donor site care are to promote rapid moist wound healing, decrease pain at the site, and prevent infection. Choices of dressings vary among burn centers and include transparent dressings such as Opsite, xenograft, silver sulfadiazine, silver impregnated dressings, calcium alginate, and hydrophilic foam dressings. Nursing care of the donor site is specific to the dressing selected. Several of the newer dressing materials offer decreased healing time, which facilitates earlier reharvesting of skin at the same site. The average healing time for a donor site is 10 to 14 days. This is a healed donor site. In a patient with large body burns, only a limited amount of unburned skin may be available as donor sites for grafting, and some of that skin may be unsuitable for harvesting. Cultured epithelial autograft, abbreviated CEA, is a method of obtaining permanent skin from a person with limited available skin for harvesting. CEA is grown from biopsy specimens obtained from the patient's own unburned skin. This procedure is performed in suitable patients in some burn centers as soon as possible. The specimens are sent to the commercial laboratory where they are biopsied, keratinocytes are grown in a culture medium containing epidermal growth factor. After approximately 18 to 25 days, the keratinocytes have expanded up to 10,000 times and form sheets that can be used as skin grafts. The cultured skin is returned to the burn center where it's placed on the patient's excised burn wounds. CEA grafts generally form a seamless, smooth replacement skin tissue. Problems related to CEA include a poor graft take due to the thin epidermal skin graft loss during healing, infection, and contracture development. This is a picture of cultured epithelial autograft. And this is a picture of a healed cultured epithelial autograft. A patient is to undergo skin grafting with the use of cultured epithelial autograft full-thickness burns. The nurse explains to the patient that this treatment involves what? Shaving a split-thickness layer of the patient's skin to cover the burn wound, using epidermal growth factor to cultivate cadaver skin for temporary wound coverage, using small specimens of the patient's skin grown into sheets to use as permanent skin coverage, or exposing animal skin to growth factors to decrease antigenicity so it can be used for permanent wound coverage. And yes, the answer is C. Cultured epithelial autograft, or CEA, is a method of obtaining permanent skin from a person with limited available skin for harvesting. CEA is grown from biopsy specimens obtained from the patient's own unburned skin. As with CEA, artificial skin is indicated for use in the treatment of life-threatening, full-thickness or deep partial thickness burn wounds when conventional autograft is not available or advisable, as in older or high anesthetic risk patients. It has also been successfully used in reconstructive burn surgery procedures. It needs to be applied within a few days of admission for greatest success. Any successful artificial skin must replace all functions of the skin and consist of both dermal and epidermal elements. The Integra artificial skin dermal regeneration template is an example of a successful skin replacement system available in burn care today. Its application requires a high degree of skill. Another dermal replacement is alloderm, a cryopreserved allogenic dermis. Human allograft dermis, harvested from cadavers, is decellularized to render it immunogenic and then freeze-dried. Once thawed, alloderm is rehydrated with ultra-thin epidermal autografts immediately before placement on a newly excised wound. Many aspects of burn care cause pain. However, patients experience moments of relative comfort if they receive adequate analgesia. To provide effective pain management, it's important for you to understand both the psychologic and physiologic aspects of pain. The first line of treatment is pharmacologic. You can see Table 2513 for more information. With background pain, a continuous IV infusion of an opioid, such as Dilaudid or hydromorphone, will allow for a steady therapeutic level of medication. If an IV infusion is not present, slow-release twice-a-day opioid medications like MS-Contin are indicated. Around-the-clock analgesics can also be used. Breakthrough doses of pain medication need to be available regardless of the regimen selected. Anxiolytics, which frequently potentiate analgesics, are also indicated and include lorazepam or Ativan and midazolam or Versed. For treatment-induced pain, premedication with an analgesic and an anxiolytic is required via the IV or oral route. For patients with an IV infusion, a potent short-acting analgesic such as fentanyl or Sublimase is often effective. During treatment activity, small doses should be given to keep the patient as comfortable as possible. Elimination of all pain is difficult to achieve, and most patients indicate satisfaction with tolerable levels of discomfort. Pain management is complex and ever-changing throughout the patient's hospital stay and after discharge. Mind and body interventions can be very effective in helping patients cope with pain. Remember, the more control the patient has in managing pain, the more successful the chosen strategies will be. Active participation in requesting timeouts and scheduling treatments and rest periods can help the patient to manage feelings of anticipatory pain. Back to the case study. MK's skin grafts are healing well. His pain is now well controlled with oral morphine. MK begins a regular schedule of physical and occupational therapy. How would you support him in occupational and physical therapy? Continuous physical therapy throughout burn recovery is imperative if the patient is to regain and maintain muscle strength and optimal joint function. A good time for exercise is during and after wound cleansing, when the skin is softer and bulky dressings are removed. Passive and active range of motion should be performed on all joints. Ensure that the patient with neck burns continues to sleep without pillows or with the head hanging slightly over the top of the mattress to encourage hyperextension. Maintain the occupational therapy schedule for the wearing of custom-fitted splints, which are designed to keep joints in functional position. Examine the splints frequently to ensure an optimal fit with no undue pressure that might lead to skin breakdown or nerve damage. When the wounds are still open, the burn patient is in a hypermetabolic and highly catabolic state. The patient may benefit from an antioxidant protocol which includes selenium, acetylcysteine, ascorbic acid, vitamin E, zinc, and a multivitamin. If the patient is on a mechanical ventilator or is unable to consume adequate calories by mouth, a small bore feeding tube is placed and enteral feedings are initiated. When the patient is extubated, a swallowing assessment should be performed by a speech pathologist before the oral feeding is commenced. The alert patient should be encouraged to eat high-protein, high-carbohydrate foods to meet increased calorie needs. If caregivers wish to bring the favorite foods from home, this should be encouraged. Appetite is usually diminished, and constant encouragement may be necessary to achieve adequate intake. Ideally, weight loss should not be more than 10% of pre-burn weight. You need to record the patient's daily caloric intake using calorie counting sheets, which are monitored by the dietitian. Patients are weighed routinely to evaluate progress. The rehab phase begins when wounds have healed and the patient is engaging in some level of self-care. This can occur as early as 2 weeks or as long as 7 to 8 months after the burn injury. Goals for the patient now are to work towards resuming the functional role in society and rehabilitate from any functional and cosmetic post-burn reconstructive surgery that may be necessary. The burn wound heals either by spontaneous re-epithelialization or by skin grafting. Layers of keratinocytes begin to rebuild the tissue structure. Collagen fibers add strength to weakened areas. Collagen fibers present in new scar tissue assist with healing and add strength to weakened areas. The new skin appears flat and pink. In approximately 4 to 6 weeks, the area becomes raised and hyperemic. If adequate range of motion is not instituted, the new tissue will shorten, causing a contracture. Mature healing is reached in about 12 months when suppleness has returned and the pink or red color has faded to a slightly lighter hue than the surrounding unburned tissue. It takes longer for more heavily pigmented skin to regain its dark color because many of the melanocytes have been destroyed. Frequently, the skin does not regain its original color. Paramedical cosmetic camouflage, the implantation of pigment within the skin, can help even out unequal skin tones and improve the patient's overall appearance and self-image. Scarring has two components, discoloration and contour. The discoloration of scars will fade somewhat with time. However, scar tissue tends to develop altered contours. That is, it's no longer flat and slightly raised, but becomes elevated and enlarged above the original burned area. Burn care providers believe that pressure can eventually help keep a scar flat. Gentle pressure is maintained on the healed burns with custom-fitted pressure garments and clear thermoplastic face masks. Pressure garments and masks should never be worn over unhealed wounds and are removed only for short periods while bathing. These garments are worn up to 24 hours a day for as long as 12 to 18 months. The patient typically experiences discomfort from itching where healing is occurring. Application of water-based moisturizers and use of oral antihistamines such as hydroxyzine help reduce the itching. Massage oil, silicone gel sheeting, gabapentin, and injectable steroids may also be helpful. As old epithelium is replaced by new cells, flaking will occur. The new formed skin is extremely sensitive to trauma. Blisters and skin tears are likely to develop from slight pressure or friction. Additionally, these new healed areas can be hypersensitive or hyposensitive to cold, heat, and touch. Grafted areas are more likely to be hyposensitive until peripheral nerve regeneration occurs. Healed burn areas must be protected from direct sunlight for about 3 months to prevent hyperpigmentation and sunburn. So MK progresses in his healing and is transferred to a rehab facility. His parents have been very involved in his hospital care and are now ready to help him in this phase. What would your teaching plan include? A contracture is an abnormal condition of a joint characterized by flexion and fixation. These develop as a result of shortening of scar tissue in the flexor tissues of a joint. Areas that are most susceptible to contracture formation include the anterior and lateral neck areas, axilla, antecubital foci, finger, groin areas, popliteal foci, knees, and ankles. Some areas encompass major joints. Not only does the skin over these areas develop contractures, but underlying tissues such as the ligaments and tendons have a tendency to shorten during the healing process. Encourage proper positioning, splinting, and exercise to minimize this complication. These procedures should be continued until the skin matures. Therapy is aimed at the extension of body parts because the flexors are stronger than the extensors. Burned legs may first be wrapped with elastic, such as an ACE bandage, to assist with circulation to leg grafts and donor sites before ambulation. Burned arms can be wrapped with a layer of tubular elastic gauze. This interim pressure prevents blister formation, promotes venous return, and decreases pain and itchiness. Once the skin is completely healed and less fragile, custom-fitted pressure garments replace the elastic bandages and tubular gauze. This photo depicts a picture of the contracture of the neck. Because the patient may go home with small unhealed wounds, teach the patient and caregiver the skills for dressing changes in wound care. If needed, arrange home care nursing services to assist with care after discharge. Water-based creams such as Vaseline Intensive Rescue, Sween Complex 15 that penetrate into the dermis should be used routinely on healing areas to keep the skin supple and well moisturized, which will decrease itching and flaking. Oral antihistamines may be used if itching persists. Reconstructive surgery is frequently required following a major burn. The need for or possibility for further surgery will be reviewed at the outpatient burn center appointment following discharge. Constant encouragement and reassurance are necessary to maintain the patient's morale, particularly once the patient realizes that recovery can be slow. Rehabilitation may need to be a primary focus for at least the next 6 to 12 months. It is essential that patients be encouraged to discuss their fears regarding loss of their life as they once knew it, loss of function, temporary or permanent deformity and disfigurement, return to work and home life, and financial burdens resulting from a long and costly hospitalization and rehab. Care should also be taken to address individual, spiritual, and cultural needs, as both these facets of the patient's life play a role in recovery. Pastoral care and cultural groups may be helpful resources to the patient, caregiver, and the healthcare team. Patients can be assisted towards a realistic and positive appraisal of their particular situation, emphasizing that they can do what they can do instead of what they cannot. In a society that values physical beauty, alterations in body image can result in psychological distress. Encouraging appropriate independence and eventual return to pre-burn activities and interactions with other burn survivors will involve the patient in familiar activities that may bring comfort and help to restore self-esteem. Counseling, which may have started in the acute phase of care, can be offered after discharge. Patients appreciate reassurance and that their feelings during this period of adjustment are normal, and that their frustration is to be expected as they attempt to resume normal lifestyle. As people age, skin becomes more dry and more wrinkled. The dermal layer thins and there is a loss of elastic fibers, a reduction in subcutaneous adipose tissue, and a decrease in vascularity. As a result, the thinner dermis with reduced blood flow sustains deeper burns with poorer rates of healing. Once injured, the older adult has more complications in the emergent and acute phases of burn resuscitation because of pre-existing medical conditions. For example, older patients with diabetes, heart failure, or chronic obstructive pulmonary disease will have morbidity and mortality rates exceeding those of healthy younger patients. In older patients, pneumonia is a frequent complication. Burn wounds and donor sites take longer to heal, and surgical procedures are less well tolerated. Weaning from a ventilator can be a challenge, although usually self-limiting. Delirium, if it develops, may be distressing. It usually takes longer for these patients to rehabilitate to the point where they can safely return home. For some, a return home to independent living may not be possible. As the population ages, development of strategies to prevent burns in older adults is a priority. Patients and caregivers have many emotional and psychological needs during the often lengthy, unpredictable, and complex course of care. You have an important supportive and counseling role as patients struggle to get their lives back on track. For you to manage the enormous range of emotional responses that the burn patient may exhibit, assess the circumstances of the burn, that is, the cause, other people that were involved, assess family relationships and previous coping experiences with stressful stimuli. At any time, the various emotions of fear, anxiety, anger, guilt, and depression may be experienced. See Table 2514 for more information. Major emotional challenges confront patients and caregivers throughout the burn patient's recovery, and perhaps for years to come. As more and more independence is expected from the patient, new fears must be confronted. Can I do it? Am I a desirable partner or parent? Open and frequent communication among the patient's caregivers, close friends, and burn team members is essential. So MK has been expressing some concern about his ability to return to work. He also states that he has trouble looking in the mirror and has been avoiding his girlfriend's phone calls. Think a little bit about the psychological impact of MK's injuries and formulate an appropriate psychosocial nursing diagnosis. A person's self-esteem may be adversely affected by the burn injury. In some individuals, an overwhelming fear may be the loss of relationships because of the perceived or actual physical disfigurement. In a society that values physical beauties, alteration in body image can result in psychological distress. It's important to address individual spiritual and cultural needs, as both have a role in recovery. Pastoral care may be a helpful resource for the patient and caregiver. The need for support, information, and family involvement may vary among cultures. Identify what's important to your patient and caregiver and communicate that information to the patient's plan of care. The difficult issue of sexuality must be met with honesty. Physical appearance will be altered in a patient who has sustained a major burn. Acceptance of any change is difficult at first, but for the patient and significant other. The nature of skin injury in itself causes modifications in processing sexual stimuli. Touch is an important part of sexuality, and immature scar tissue may make the sensation of touch unpleasant or may dull it. This is usually transient, but the patient and partner need to know that it's normal and should receive anticipatory guidance from the healthcare team to avoid undue emotional strain. Caregiver and patient support groups may be beneficial in meeting the patient's and caregiver's emotional needs at any phase of the recovery process. Speaking with others who have experienced burn trauma can be beneficial, both in terms of reaffirming that the feelings of the patient are normal and in allowing for the sharing of helpful advice. The Phoenix Society, www.phoenix-society.org, is an internationally highly respected burn survivors support group that has been offering invaluable support and resources for many years to burn survivors, caregivers, and burn team personnel. Warm, trusting, and mutually satisfying relationships frequently develop between burn patients and nursing staff, not only during hospitalization, but also during the long-term rehabilitation period. You may find it difficult to cope with not only the deformities caused by burn injury, but also the odors, the unpleasant sight of the wound, and the reality of the pain that accompanies the burn and its treatment. Do not hesitate to seek help from coworkers, a manager, or the Employee Assistance Program should you feel the need. In time, you will come to know that a specialized burn care that you provide makes a critical difference in helping patients not only survive, but also to cope with and triumph over an intense and multifaceted injury. It is this belief that will allow and inspire you to provide meaningful care to burn patients and their caregivers. Ongoing support services and critical incident stress debriefings led by a psychiatrist, psychologist, psychiatric clinical nurse specialist, or social worker may also be helpful to you. Peer support groups can serve a similar purpose by helping you to cope with difficult feelings you may experience when caring for burn patients, such as the ABA, the International Society for Burn Injuries. Because burn nursing is physically, psychologically, and intellectually demanding, it has many challenges and inherent rewards. Attention to your own self-care is important if you are to maintain a positive attitude and healthy work-life balance. Time with family and friends and rest and relaxation at home are essential parts of self-care and a balanced life with purpose and meaning.